Welcome to our 38th edition of Global Healthcast, brought to you by Global Health Press. In this broadcast series, once a week, we bring to you news and views about infectious diseases, vaccines, and vaccination. Today is May 23rd, 2023. I am Joe Schmitt, and with me is Dr. Melvin Sanicas. Good morning, Melvin.
Good morning, Professor Schmitt. Good morning to you guys who are watching us. Good afternoon or good evening, depending on where you're from or where you are at the moment.
We're very happy to have you with us today, and our topics will be what to expect at the end of the PHE for COVID, and Melvin will explain you what that means. SARS-CoV-2, how it all started. I will report about the VACCELERATE network on RSV, bronchiolitis, and recurrent wheezing and asthma. And then Melvin will continue with the most infectious diseases, and today he will cover Ebola and Marburg. Melvin, let's get started. It is the end of the public health emergency of COVID pandemic. So what is your view here? What do you want to tell us today?
Yes, that's right. And so, Professor, just to remind everyone, the public health emergency, the PHE, status of COVID ended a couple of weeks ago, not just for the global declaration by the WHO, but also in the US. It ended in May 11th. And so I think people have to have an idea of what can we really expect, right, when this public health emergency ends. So maybe we discuss what will not change. So access to COVID vaccines and COVID antiviral treatments generally will not change. Although I would imagine that the cost of these vaccines or antiviral treatments will vary depending on where you are at the moment. So because of course, the cost of these vaccines and treatments and even the testing, they were shouldered by the government, right? And so they will still be there, but in terms of the cost, maybe it will vary depending on where you are at the moment.
From my perspective, the pandemic is over, but the virus will stay. And now looking back, there are good news and bad news. The good news is digitalization really went a big step forward. Now we have home office, many things have become easier. At the same time, the negative aspect certainly was these quarantines where people had to stay home, children could not go to schools, many negative things happened. But at the same time, there was a push to innovation in many societies, and particularly as I'm living in Germany, this really has woke up our country when it comes to digitalization. So I think there were some positive aspects despite all the negative aspects. I want to highlight one more caution here as well. From my view, we had now 3 outbreaks of coronaviruses. The SARS coronavirus 1 epidemic, epidemic or outbreak in Hong Kong, and then the MERS coronavirus, and now we have the pandemic with SARS coronavirus 2. And that was roughly every 10 years. So the prediction could be there will be a next pandemic with another coronavirus in about 10 years. So we should use the opportunity to get ready for the next pandemic from coronavirus, from influenza virus, or from disease X that Melvin has been talking about in the past and will talk about again later today. Melvin, you share this view or any other views or any additions?
Yeah, and also maybe another thing to highlight, Professor, is the fact that with the COVID public health emergency, the governments had a lot of funding or money put into measures to end COVID and also research, right? So this will also be reduced. For example, studies of tracking the variants, or let's say funding for research of COVID will gradually decrease because it's no longer a public health emergency.
Yeah. Very good. We may have more thoughts in the next couple of weeks. I think this topic will not leave us, will not be gone forever, but it will continue in different aspects. So stay tuned. And I thought it is a good idea to go back where it all started. And right on time, this paper was published in Nature. And it is from the Chinese Centers for Disease Control, and they published their original findings from the Huanan seafood market. And what you can see here, very early on, before the start of the pandemic, they did all this surveillance in this local market. And what you can see here, they isolated the original SARS coronavirus 2 from patients here in red, confirmed patient here, and here in the market, and here is one. And then they found it in domestic wildlife products. This is the red shade, the gray areas with the red circle, with the red lines around here, 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 here. And then it was found in these orange type colors in environmental samples and in sewers or sewerage. There was PCR positive samples. I think this is very convincing evidence that the pandemic started at the Huanan seafood market, when the virus jumped from animals, whatever that may have been, to humans. The big question that I have is why do they publish this now? The alternative explanation had been that the virus comes from the Wuhan Institute of Virology, and it escaped somehow from this laboratory there and then caused the pandemic. Look, if they would have come with this data right away, this would have been very convincing. Now one can say, why do they come that late with it? And is this real data, or did they make up the story here? There is a little funny feeling with the data being published 3 years after the event. Melvin, what is your view on this? You have been living in Asia for quite a while.
So my personal thoughts on this is that China in general and many other countries in Asia, they're not really very open about things, about publishing and results of events in their countries, right? And China is known to be one of those countries that is quite secretive. And I think during the start of this pandemic, they were trying to solve it on their own, and they plan to publish this after they've solved it. But then they were not able to solve it, and it spread all over the world. But also, to their credit, we should remember that just a few days after this virus was sequenced, the scientists shared the genomic sequence to everyone, right? And that's the reason why BioNTech, Pfizer, and Moderna, and many others, they were able to create a vaccine candidate from the genomic sequence that they shared. And so I guess you can look at it both ways, but I think I would say that because of all these animals stacked up in different cages, right, in this seafood market, the probability of the virus developing from all these different animal interactions in this seafood market is really quite high.
Yeah, it is convincing in itself, right? This is a plausible story. There is good plausibility that this is all true, but better communication would have been very helpful. Can we agree on that? Yeah, very good. Correct. Now, as a response to the COVID outbreak, and you see, we stay with COVID today, although we don't really cover any details on the epidemiology anymore. As a response to the outbreak, what happened in Europe is people saw clinical trials is really something we're not very good with. There are many institutions that do immunogenicity studies, but this is not enough, right? If you know, if you have antibodies or T cells against a certain vaccine or against a certain infection, that doesn't mean you're protected. So you really need to get better with regard to clinical trials looking for protection. Now, in the wake of the pandemic, or as a consequence of the pandemic, the European Union funded VACCELERATE, which is a European network of sites that are willing to participate in clinical trials. By today, 481 sites from 39 European countries have registered in the VACCELERATE site network, and all the details you can see here in the publication that I've listed down here. Actually, 28.5% of the sites have experience with conducting phase 1 trials, 53% with phase 2 trials, and 70% with phase 3 trials, which I think are the most demanding ones. And phase 4 is already 42%. So I think there is a good experience there already, but now they're all connected and able, in principle at least, to do clinical trials in the situation where this is rapidly needed. And I can tell you, there's a lot of effort going on to speed up trials and to make sure that in case of a next pandemic, there will be a much quicker response than there has been before. And just from this same paper here, what you can see here, various vaccine trials have been accomplished. I think right now this adds up to 21 studies. Some of them are academic, many of them are largely epidemiological studies. It is certainly very difficult for academic sites to run trials with own vaccine ideas. I think this is really, really difficult and very costly. And our institutions, our academic institutions, are not funded in a way that they could run any phase 1 or 2 trials with their own vaccine ideas. And I think it may not even be a good idea if they do that, because there is no knowledge on the way to licensure and on the way how to do all the details that are needed to come to a product that makes it to the market in the end. In any event, I think this is a great initiative, and I think with the efforts that are ongoing, I will inform you about that in the future, pretty sure. I think Europe is in a much better place than it had been before the pandemic. Melvin, any views, any comments?
And Professor, just to clarify, so this did not exist before COVID, right?
Right.
So really this was created so that in the future, when there is the next COVID comes, it will be much faster to really test whatever vaccines, antivirals, or diagnostics will be developed within the European Union, right?
Yeah. That is the hope, and that is very likely to happen. Yeah, I agree. Yeah. In any event, I have a next topic, which is respiratory syncytial virus and recurrent wheezing, RW, and or asthma. We reported before in our Global Health Cast that respiratory syncytial virus, RSV bronchiolitis, is associated with the development of recurrent wheezing and or asthma later in life. Now, first of all, recurrent wheezing is a symptom. If you have asthma, then you have recurrent wheezing, but asthma means you have this wheezing for a prolonged period of time, probably for the rest of your life. So asthma is something that is, chronic. And recurrent wheezing is a symptom that may be short or may develop into something that you would call asthma later on in life. Now, in this study that was just published from Tennessee, they start with saying that there's an association between RSV bronchiolitis and a subsequent elevated risk for recurrent wheezing and asthma. This is what we know and we told you about before. The problem is the RSV virus the cause of recurrent wheezing and asthma? This is unknown. Now, what the authors did is they did a retrospective population-based cohort study on more than 300,000 children. So they looked into charts. And their finding is, if there was bronchiolitis during the first years of life, regardless of the etiology and severity, this was associated with an at least threefold increased risk of recurrent wheezing and asthma at 2 to 4 years, and increased prevalence of asthma at more than or 5 years and older. So the interesting thing is, it is not RSV, but the association existed regardless of the etiology. And furthermore, they found that the risk was similar, the risk for recurrent wheezing and asthma was similar in children with mild bronchiolitis and in those with hospitalized or severe RSV bronchiolitis. And it was even higher in children with hospitalized non-RSV bronchiolitis. The rate of recurrent wheezing and asthma was higher when bronchiolitis occurred after the first 6 months of life. 60% of hospitalized bronchiolitis cases settings were due to RSV. And that makes the point. In the past, everybody said if it is bronchiolitis, it is RSV, but nobody looked for the etiology. And now looking back, the RSV etiology was only confirmed in a fraction of patients, right? And now it may well be, and that is the conclusion of the authors, the hypothesis that there is a shared predisposition to bronchiolitis. And if you have this genetic predisposition, irrespective of the virus that you are infected with, you may develop recurrent wheezing and asthma. So it is not the virus is the trigger, or the virus unmasks your predisposition to bronchiolitis. This is the finding of that paper, which I think is a very nice hypothesis. The one way to find it out is you vaccinate 100,000 children with an RSV vaccine, and in 100,000 children you do not vaccinate with an RSV vaccine. And then you look for 5 years how many children in each group develop recurrent wheezing and or asthma. And then you will know if there is any causal relationship between RSV and recurrent wheezing and asthma. I remember from my industry past that it is very difficult to come up with a definition of recurrent wheezing and asthma in children. We interviewed many experts and there was no agreement. So such a study is very difficult to be done. And I'm not sure if it ever will be done. But with this data here, I tend to say I tend to agree with the hypothesis that there's a genetic predisposition, and irrespective of the organism, you will later on develop your recurrent wheezing and asthma. A complicated story, Melvin, but look, they just put the numbers in a graph, which the graph is difficult to understand because of the abbreviations. PB is registered bronchiolitis and primary care or hospital, so no PB, that is a 1 for the odds ratio. And if you have a first bronchiolitis consultation in primary care, the risk is 3 times higher. And the same is true for severe RSV, and even for miscellaneous bronchiolitis, irrespective of the organism, right? Non-RSV included, it is almost 4, right? And the same is true for severe non-RSV infections. This is really high. So this is the summary slide here again and again. It is easy to see, but difficult to understand all the abbreviations here. Any thoughts from your side?
2 things, Professor. So I think the first thing is it makes sense biologically that bronchiolitis, whether it's RSV or maybe some other virus similar to RSV, could potentially trigger recurrent wheezing or asthma. And the second thing is, I think this is something that VACCELERATE can actually do something on. They can test future RSV vaccines to see whether this vaccine could actually decrease asthma or recurrent wheezing in kids.
You would have to randomize, and as the vaccines are coming along, I guess it will be difficult to give a placebo. So I see the point. So in the end, you will not be able to do a double-blind randomized study. You can only do an observational study.
Yeah.
And then you don't, that can always be challenged with regard to the causality assessment. But in any event, let me think about it, and there may be opportunities, right? Mm-hmm. In the end, what you need is a very big sample size. That's the issue here. Yeah.
Yep.
Melvin, you cover now the next most infectious disease. We are now with Ebola and Marburg.
Yeah, so we have been covering here some of the most infectious diseases that the WHO has identified. So for you out there watching, you may be saying, why is this not included? Why is this not included? So these are the viruses, the pathogens that the WHO identified. And this list was created before COVID. And the reason why we are discussing them, because almost all of them actually have no antivirals or vaccines approved to date. And we've discussed all these different other viruses. So if you want to learn more about Nipah virus, and others, go to our different Global Health Cast episodes. And today we are going to discuss Ebola and Marburg virus. So diseases caused by Ebola and Marburg are actually so these diseases that are caused by Ebola and Marburg are counted among the hemorrhagic fevers. So the causative agents are viruses of the genus Ebola virus, which together with the genera Marburg virus and Cuvivirus belongs to the family Filoviridae. So they are filamentous shaped virus. So as you can see here, they look like filaments, right? That are long strands, and you will see that Marburg and Ebola virus here look similar. And if you Google Ebola and Marburg, these are the photos that you will see. So Marburg and Ebola viruses cause clinically similar diseases characterized by hemorrhagic fevers and capillary leakage. So in the context of the Global Health Cast, I will just mention Ebola virus infection because Ebola virus is slightly more virulent than Marburg. And that's why we will, moving on in the slides, I will just say Ebola. Okay.
Very good. And by the way, Marburg is from an outbreak, or not from an outbreak, but the Marburg virus was imported to the city of Marburg from Uganda when the vaccine producer Behring imported whatever type of little monkeys for their development program to the city, and then they isolated the virus. So this was the Marburg virus because it was first isolated in the city of Marburg, but it comes originally from Uganda.
Yeah, that's right, Professor. And also interesting to note that the name Ebola is from the Ebola River in the Congo. So the name is actually from the place it was discovered.
Yeah, interesting.
Yeah. So now we discuss how Ebola spreads. This image is from the UNICEF, WHO, and Uganda, and I think it's pretty simple to understand, and it's pretty clear. But you will see here that the virus is actually can spread in many ways. Scientists think that fruit bats of the Pteropodidae family are the natural Ebola virus hosts, and it is introduced into the human population through close contact with blood secretions, with organs or other bodily fluids that have been infected by infected animals such as fruit bats, chimpanzees, gorillas, monkeys, antelopes, porcupines, or other mammals found sick or dead in the rainforest. Then Ebola spreads through human to human transmission via direct contact through broken skin or through the mucous membranes.
So it is highly contagious.
Yes, it is quite contagious. Yeah.
And you can get it by direct contact with an infected person or with
fluids,
with clothing, with food. Yep. So it is really very contagious.
Yes, it is. And that is the reason why for many of the past Ebola outbreaks, it was quite difficult to control because it is really quite contagious.
Yeah, interesting.
And then on the next slide, you will see how basically this is answering the question, how does one get Ebola? So human-to-human transmission happens, as I've said, via direct contact with blood or body fluids of a person who is sick with or has died from Ebola. And objects that have been contaminated with body fluids like blood, feces, vomit from a person sick with Ebola or a body of a person who has died from Ebola. That's why I've been emphasizing that, because even for bodies, right, dead bodies of people who have been infected, it is possible to get the virus. And it's also possible to contact the virus from semen of a person who has recovered from Ebola, because studies have shown that even after someone recovers from the virus, like without symptoms, the virus can still be isolated from the person's semen. So that is another way of spreading of Ebola.
That is very interesting. So the virus is in the person despite the person is no longer sick, and despite the fact that there's immunity to the virus. If there was no immunity, the person would be sick, right? He would have hemorrhagic fever and die.
That's right.
So it must survive in niches there, right? There must be niches where the immune system cannot detect the virus, right? Interesting.
Yeah. And then in the next slide, you will see how does Ebola spread from person to person exactly. So the symptoms of Ebola infection can be sudden, and it can include fever, fatigue, muscle pain, headache, and sore throat. So basically like other respiratory pathogens. And these are followed by vomiting, diarrhea, rash, and internal and external bleeding. The time from when someone gets infected to having symptoms is usually from 2 to 21 days. So it's a huge
incubation period.
The incubation period is actually quite long. And a person with Ebola can only spread the disease once they have symptoms. And people can spread Ebola for as long as the body contains the virus. And like I've mentioned, for those people who have recovered, even if they don't have any symptoms, they can pass the virus through their semen. So that even makes the virus more sinister, I would say.
Yeah. Melvin, would you happen to know how long the once infected person may carry the virus without any symptoms? Is this for years or for days or for months? I guess it is not known probably, right?
So I guess that will be difficult, but there is a study showing that up to more than 100 days, someone with a man in this report show that he still has this virus even after 100 days.
Wow. Wow. So that is really something. Yeah.
Yep.
All right.
And then on the next slide, you will see that, as I've mentioned, scientists think that people are initially infected with an Ebola virus through contact with an infected animal, right, such as a fruit bat or a non-human primate. And the virus is easily transmitted from animals to humans during hunting, slaughtering, and preparing of the animal meat. So after that, the virus spreads from person to person, potentially affecting many people in the community, especially since the incubation period is quite long. And although we can say that typically it's from 2 to 21 days, but even after that, it's quite difficult to really say that a person has this virus until you do the testing, right? Because the symptoms, the initial symptoms can be like any other diseases.
Yeah. So that is very interesting because people need food, right? And they hunt animals all the time. We do this in Europe, they do this in Africa. But once the virus is in these animals, you have a problem. So it's a little bit like with rabies. You may get infected with these animals that are around you, and it really poses a big problem. You cannot get rid of the reservoir, right? You cannot eliminate the reservoir. You cannot eliminate bats.
No,
so
that's right.
Very, very difficult situation. Yeah.
And then finally, we talk about the next slide, which talks about how to prevent Ebola or the infection with Ebola. So since I mentioned that it's passed through human direct contact, it's really important to avoid contact with semen from a man who has recovered from Ebola, avoid contact with items that may have come into contact with an infected person's blood or body fluids. Okay, so now we talk about ways to prevent Ebola infection. So when living in or traveling to a region where Ebola viruses are potentially present, there are several ways to protect yourself and prevent the spread of Ebola disease. So most importantly, avoid contact with blood and body fluids of people who are sick. It's also important to avoid contact with semen from a man who has recovered from Ebola disease. Also avoid contact with items that may have come in contact with an infected person's body or body fluid. It's also important to avoid contact with bats, forest antelopes, non-human primates such as monkeys and chimpanzees, and the body fluids of or raw meat prepared from these animals. But we should also mention that there is an approved Ebola vaccine. It's called Ervibo. It's a replication competent live attenuated recombinant vesicular stomatitis virus, or the RVSV vaccine, manufactured by Merck, and it was approved by the US FDA in December 2019. This vaccine is given as a single dose vaccine and has been found to be safe and protective against Ebola virus, species Zaire Ebola virus only, which has caused the greatest and the most deadly outbreak to date.
Very good. Thank you very much for the update on Ebola. And I guess if you're traveling, this is important information. And I guess with this, we come to an end for the Global Health Cast today. We covered what you may expect from the end of the public health emergency for COVID. I told you about the publication of the Chinese Centers for Disease Control with their findings very early on, before the pandemic, even from the Huanan seafood market, where they isolated the virus from patients, from confirmed patients, as well from animals, as well as from sewage. I told you all about the VACCELERATE network, how this has been set up as a response to the pandemic to make sure that clinical trials can be done throughout Europe with appropriate speed. And I spoke about one paper on RSV, bronchiolitis, and the recurrent risk for wheezing and asthma. And actually, the risk for wheezing and asthma seems to be independent of the RSV virus. And according to this study, the new hypothesis is that there is a predisposition, and independent of the virus that may cause the bronchiolitis, you will later on develop your recurrent wheezing and or asthma. And finally, Melvin showed you we gave information on two hemorrhagic fevers, Ebola and Marburg virus, and how to prevent to become infected. And the information is also that there is a vaccine now that is licensed. Thank you, Melvin. This was our Global Health Cast on May 23rd, 2023. Today's slide presentation you will find in our show notes. Please like, share, and leave your comments below. Thanks for joining us today. I am Joe Schmitt.
And I'm Melvin Sanicas. Thank you, everyone. Stay safe.
Bye-bye.
Bye-bye.